Welcome to today's episode of the Back in Shape podcast. Today we're going to be talking about the question of which imaging is going to be better for you if you have lower back pain or sciatica. Is it going to be x-rays? Is it going to be MRI? And with all of our episodes, if you've got any questions, use the comment section underneath. This may raise some questions, some curiosities. Share those with us in the comments and we read and reply to all of your comments to help shed light on some of the things that maybe we don't cover in the episode itself. There'll be additional questions unique to you that you might have, so you can always pop those down there in the comments. Well, the first thing we want to think about is with imaging period is what is the objective we're looking to perhaps do? In most cases, our practitioner, our surgeon, our GP is looking to do. Well, the first thing is we're looking to attain a detailed diagnosis of precisely what is going on. And for what purpose? Well, we kind of discussed that a little bit in the last episode of the Back in Shape podcast. You can definitely check that out because that was talking about should we even bother with imaging and to what degree is that necessary? But they're going to be looking at, on this image, this scan, whatever it is, what is going on precisely in the soft tissues in that lower back? Where are the discs perhaps bulging? What is the quality of the discs? Are they degenerate? Are they herniating? Are they just, is there a minor bulge there? Is there a complete sequestration? Are bits of the disc caught behind the posterior longitudinal ligament? Is there ligament hypertrophy in the back of the spine? All of these sorts of questions are looked to be answered, and a lot of them pertaining to some of the soft tissues that are in and around the lower back. To understand then, what can we do from the next steps point of view? Because in the scenario, especially here in the UK, that you've been referred for the imaging, you've tried physio, you've tried maybe some osteo, you've tried some painkillers, you've tried doing nothing, and now we're thinking about injections, we're thinking about surgery. So the MRI particularly is going to give us the answers to those questions. Let's chop this bit off there, let's shave that bit down there, let's put an injection in here to maybe test some things. That's the one purpose of our imaging. The secondary purpose, which isn't really discussed as much, is going to be how can we use this imaging to educate the patient? How can we use this imaging to help you understand your body? How perhaps that injury is within an injured segment, is within an injured spine, although the most of the spine is actually perhaps healthy, but that particular segment is the bit that's injured and worn. And how does that spine have to function in your body in real life on a daily basis with all the things that you have to do? That is another very important question. I would argue much more important, because that is what holds the keys to your success, to your rehabilitation, to you modifying the things that have led to your injury. Because if there's one thing we know about back pain, it's not caused by a one-off occurrence. There will be so many things on a daily basis that perpetuate your back pain, that have perpetuated the weakness that has led to your sciatica. And those things can be improved, or our understanding of those things can be improved with the use of imaging. We can start to really appreciate it. And we'll get onto this a little bit more later on in the podcast. But if we circle back to actually looking at the spine, looking at what is going on in that lower back, we want something that looks at it in the way in which it functions in the real world. Many of us with lower back pain will have a proclivity to ignore or to avoid any load-bearing scenarios. You will never get someone who has a lower back injury going, yep, load me up, I'll carry the rucksack, I'll carry the suitcase, I'll move the sofa for you. You want to, at all costs, avoid load. And that might be additional load. It might be just the load of your own body. It might be the load of your own body in certain positions because it stresses tissues. Well, that's very important information, because if you are load-bearing, and then when you go offload, the symptoms perhaps abate, and that might be certainly to do with some of the positions that you adopt when you're lying down, let's say. But most people with back injuries will find that being off weight bearing is a better position. It's more relieving, it's more bearable. And that's very, very important, because what is it about standing up that maybe is different to lying down? Perhaps that puts strain on certain tissues in ways that could be revealing if we were to capture that information at the time. I use the example of a bucket. If a bucket's got a hole in it, it's very easy to find the leak if we just put load through the bucket by putting water in there, and then we can set about doing things to perhaps remedy that issue. But with the spine, it's a different kettle of fish. We might want to see some of those soft tissues if we're thinking about doing surgical intervention. So how can we go about looking at the spine under load so we can most accurately understand how this spine is having to load bear in the real world? And it's worth bearing in mind, if we're looking at the spine upright, that is the best possible position. It's the least compromised position that it can bear load in, let alone if we're slightly tilted off to one side, we're bending forwards because we're picking something up, we're sitting down. All of those things will be more inefficient. So we want to have a look at the best possible scenario. And then from there, when we're standing up and we see that spine standing, whether it's via MRI or X-ray, we can then make assumptions, and we can make inferences as to how that spine might function in a seated position, in an additional load-bearing position, maybe moving around, etc. We get a starting point, if you will. And then that gets onto the question of, well, can we do a standing MRI? Yes, we can. But those machines are very, very costly to get them done. You will not get them done on the NHS over here in the UK. And there's not that many of them in the country as well, compared to the lying down MRIs. So chances are, if you're getting an MRI, you're going to be stuck in the tube lying down, because you have to be in there for 30 to 60 minutes. And if you've got back pain, what did we just discuss? Standing is often, load bearing is often a problematic position for you to be in. So having to stand and stand still, because the image works by you being still for 30 to 60 minutes, is just off the cards for many people with severe back pain. And it's often those with quite bad back pain that will be referred to for the imaging. So it's no good then and sticking that person having to stand up for 30 to 60 minutes still. You're just likely to not get a usable information and make the patient very, very uncomfortable. And that's where things like x-rays come in. Standing x-rays are very, very easy and very, very quick to take. You can put the person in the best possible position to start with, or tell them to stand up straight. Most people should be able to effortlessly do that. Even if there's a little bit of pain, they could do it for a moment to take a photograph, fundamentally. Now, the x-ray itself has limitations for that first thing we discussed earlier on. We're not going to see the nuance of the disc that's perhaps bulging this much this way or this much that way. We're not going to see the ligament hypertrophy quite as much, although if there's ossification, we can start to pick that up on x-rays. We are, however, going to see that the disc space, the space between the two bony vertebrae, has reduced, and maybe there's some spurs coming out, so we can infer that that segment is degenerate. And then we can compare that to segments above to see, actually, yeah, that particular segment is really quite significantly more degenerated than the others. And maybe that then gives us some insight into how that spine has been load bearing for a long period of time, and how that particular section has had forces focused through it compared to many of the others, and how we might then use that information. And I'll touch on that a little bit later on, because we've got a few little action points at the end of today's episode. But fundamentally, whether it's MRIs or whether it's x-rays, they both give you usable information. The big flaw, definitely nowadays, is in how that information is used. Quite frankly, a lot of osteopaths, and unfortunately more and more chiropractors, and certainly physios, they don't have regular intervention or regular usage of imaging in their day-to-day practice. They just don't have the volume of experience when it comes to imaging. And we discussed that again a little bit last week. And so they're not really going to be able to use the information, whether it's an X-ray or an MRI. 9 times out of 10, they'll probably just get the report and read the report. They won't actually look at the imaging, so they can't do the very important part, which we'll get onto later, which is use that to educate you and to help you with your strategies going forwards. And then the other thing is, well, then if we've got the surgeon who is qualified and they're seeing these things all the time, the orthopedic specialist, the neurosurgeon, etc., those guys, or just the neurologist, they're seeing these things all the time. They do have the competence to be able to impart that wisdom to you. One of our members was sharing with us the other week after one of our posts, I can't remember which one it was some average stats, and this was for the US, but the similar sort of situation will most likely be here in the UK, that I think it was about the 1950s or 1970s, the average specialist, so doctor, surgeon, whoever, was having their initial consultation was like an hour long with the patient, and then the follow-ups on average were 30 minutes. Nowadays, it's about 12 and 5 or 12 and 7 a piece. You cannot possibly give all of the information from the qualified person who knows what they're talking about. They can't possibly impart all of that information onto you in a way that's usable for you to affect, in a positive manner, your daily life. So the person who's most equipped to help you with that translation, using the information from the MRI, even though it's lying down, there is some usable information there to help you better understand your body and understand how some of those things could be perpetuated by the things you're doing on a daily basis, and make some recommendations there. They're just not spending enough time with you because they can't in the system that we have here in the UK specifically, but also evidently in the US. They can't give you the information. And the people that are managing you and helping you on a daily basis, in most cases, don't have the experience or the exposure to imaging to be able to have the knowledge to help you with those images. So there's this massive disconnect. There's this panacea of information. No, it's not going to fix your lower back, but a panacea to provide education and understanding, whether it's an MRI or an X-ray, to help you understand your lower back and the injury that's happening there, and how that applies to your spine, and how that applies from your spine to your body, and how we can make improvements going forwards. But there's no one there to really translate it for you by and large. Now, we find when we go through it with members on virtual consultations, when we're going through the X-ray imaging, and when we would go through that in clinical practice over the years, you're spending 45 minutes, an hour going through this stuff to help the patient. This is what's going on. This is how it's working. And then this is how it can impact what we're doing from a rehabilitative point of view. This is how it can impact what you're doing on a daily basis. This is why some of those things are problematic. This is why some of those things that you didn't know were problematic are problematic, and how we can modify those things. It's not a case of just saying, no, 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 no. It's a case of understanding and then modifying and tweaking things, using this information as a tool to help you, rather than just as it's used so often, we get that MRI and we're going to just chop that bit of disc off. And that's well, there's nothing there, just carry on, when there are things there. A little pet peeve of mine is when people come back and say, I had an X-ray on MRI, I'm 30, 40, 50, 60 years old, whatever it may be, and nothing came back. No MRI, no X-ray ever comes back with nothing. And that's a significant failure of whoever gave you that report not giving you the information properly. So if you've got that on your finding and that's what you've been told, you need to go and speak to someone else about the same thing, because nothing comes back with nothing on any of these scans. The final thing I think I'll close this off with, and again, if there are any questions, guys, I know there's a lot of disparate bits of this particular podcast that might spark questions for you guys. So use those comment section, because it is a bit of a complex topic, and you'll have heard all sorts of different things, as we discussed last week, on the use of imaging, etc. But I want to finish off with a personal favorite. And my favorite with regards to the imaging is going to be the X-rays. And firstly, this is because we've seen people clinically over the years where they've had MRI images. The surgeon, the specialist, the osteopath, whoever it was, has said, oh, we've got a disc bulge here, which they did have on the MRI. You can see it. It's maybe quite a bad disc herniation. But because it's lying down and they're relying on that lying down image, they never saw the spine under load. And this happening once is enough, because that MRI might guide a surgical intervention, a surgical fusion, whatever the case may be. When we then X-ray that person standing up, all of a sudden you realize that that disc bulge, which we think is a compressive force, is actually a spondylolisthesis. It's compression and shearing, and the vertebrae are misaligned significantly. So it's maybe a grade 1, grade 2 spondylolisthesis. That completely changes a basic disc bulge or disc herniation to a spondylolisthesis. And if we're talking about things like surgical interventions having a risk-reward model, the risk-reward model is very different if we're talking about a spondylolisthesis, especially if we don't know it's there, compared to a regular disc bulge. And seeing those being missed on MRIs and that valuable information not being gathered, it doesn't happen often. But if it happens, if it's got the propensity to happen, and X-rays are so easy to do, why would you want to miss out on some valuable information to at least validate that if we are going to go down the surgical route or whatever we are going to take, we fully understand how that spine load bears upright? And for practical reasons, doing the standing MRI is just not going to work because of the time duration that you have to be in there and the inaccessibility the machines themselves are in the UK. So that's something very important. But the X-rays themselves, what do they give us? They give us, as I said, maybe less information about the soft tissues, or definitely less information about soft tissues, but they give us some information about the soft tissues, generally speaking, and slightly indirectly. But again, we discussed earlier, the diagnosis, the specific nuances of the diagnosis aren't necessarily that important. They are important to a degree, but 10 people, as I said, with a disc bulge, or 10 people with this degeneration or that issue will often, especially when it's the lower back, will have 10 different sets of symptoms. And by the way, 7 of them or 3 of them or 2 of them might not even have any symptoms at all. So that starts to show that the actual detail there is not as necessary as one might initially think, because we don't have the capacity, especially if we're not doing a surgical intervention. Your practitioner doesn't have the capacity to deal with the disc bulging to the left by 1 degree or to the right by 10 mil. They don't have the capacity to make any differences in their approach based on those particular things. And if they feel like they do, they might be being a bit overconfident in their abilities and in what they can realistically do. And that's a whole another can of worms. The X-ray itself gives us that spine under load. And that can then be used to help you appreciate how your spine is load bearing, where certain load might be focusing, certain forces might be focusing around the same segment, and why that particular segment is more worn than other segments. It's not because you're old, otherwise all of the segments would be the same, but it's something you're doing and have been doing for a long period of time, is focusing things at that level. Then we can see the alignment. How do things line up? How do the bones stack up on top of one another when you are standing in the upright position, knowing that that's going to be slightly worse in most cases when you're sitting down because of the virtues of sitting, or the reality of sitting and how that affects the biomechanics. You will, unfortunately, in some cases with some professionals, and it's going to more likely be experienced with a chiropractor because they're more likely to have done X-ray imaging, that people make a mountain out of a molehill. You're 1 degree off here, and all of a sudden the whole world is going to explode, and you definitely need to fix it, or when we've heard those sorts of horror stories, which are just completely off. But if we are talking about significant spinal abnormalities, maybe you're supposed to have a 40-degree curve through the lumbar spine. The lumbar spine is supposed to have a natural lordosis to it, and you have like 10, or your spine is straight and it should be curved. That can have influences because we can do something about that on the gross level. We can intervene there and we can make improvements. So knowing about that and how that maybe feeds into the common prescription of knee hug exercises. So let's just use the example of if your spine should have a 40-degree backward curve to it, which is natural, and we can be quite a wide berth around that. 10, 20% either side is completely okay. It's not a big issue to be either side of that. So we've got quite a wide range that a normal spine could be in. And bear in mind, those normals from a research point of view are based on normal, healthy people. So there is a wide berth. But if we're down and we've got a straight spine, that's 0 degrees, and we should be 40, this is just using numerical examples here. If your spine is flat, no wonder your knee hugs are not working, because you already have a flat spine, and you're taking your flat spine and you're rounding it even more. This is one of the fundamental reasons that knee hugs are so silly, because so many people, if you have long-standing lower back pain, chances, and I'm talking about long-standing lower back pain or sciatica, chances are that you have a flatter than normal lumbar spine, or the chances are significantly higher. The short-standing lower back pain, I've had it for a week, I've had it for a few days, different kettle of fish. But when we have long-standing lower back pain, the chances that you have a flatter than normal spine to a significant degree is reasonably likely. This is one of the reasons that we don't advocate knee hugs, and we do advocate for the towel to put your spine in a better position on a daily basis. But we can see those things and we can measure those things and we can start to be objective. The next thing we can do with the load-bearing x-rays is we can say, hey, this is your spine. And we can start to, and that's why I said earlier, those appointments are 45 minutes, 60 minutes to help you understand what's going on, understand your spine, understand why maybe certain things are going to be better for you in the short term and how we want to work towards other things over the long term. But we acknowledge that there are some fundamental features of your particular case that we can see on the load-bearing image, and then we can make adaptations for that short term and work on improving certain things that we can improve, and also being realistic and saying, look, we can't improve this, perhaps we can't change this, but we can compensate for it, and that means that it doesn't need to be a problem long term, providing we do the appropriate compensations. And we can be long-term in a much better position than we currently are, symptom-wise, lifestyle-wise, ability to do things-wise. So that education is so very important. And you can get that with MRI and X-ray, but the X-ray just gives you that additional insight. The load-bearing image, that's the important thing. The load-bearing nature of the image gives us that additional education tool to help you understand what's going on. And finally, especially relevant to those of you that have osteo, physio, and chiro appointments where there's been physical observations being made, or a leg length, anterior pelvic tilt, etc. We can assess the objective validity of those statements, and 9 times out of 10 dismiss the statements that have been made before because they're so inaccurate, and often they're just inaccurate and not worthy of really considering. Because quite often those sorts of statements of anterior pelvic tilt, need to do posterior tucks, short legs, twisted spines, all this sort of stuff, those statements are so inaccurate, but they're valued by the patient so much, disproportionate to their validity. And by using imaging, we can rule in or out the validity of those things. Sometimes they are there, and we need to then do something about them, or we can do something about them, or we can't do something about them, and we can, again, compensate. But we can actually assess and get a solid answer of yes or no. Is this an issue in my spine? Is it compensating or contributing, to my problem? So that's really how we can use that imaging. Yes, we can get some information to help you better understand your case from the MRI, but it's off load bearing, and that has critical flaws from a usability and a helpfulness for you, the patient, to take that information and then incorporate it into the way in which you use your body on a daily basis and move forward in a more productive manner. You need someone who's going to be able to go through that with you and impart the wisdom. And quite frankly, unfortunately, the people best placed to do that are often the people that have the least time to do that, unfortunately. And that's just the way, unfortunately, things are. But hopefully, this episode has given you a better understanding of X-rays versus MRIs. In short, MRIs give you way more diagnostic, soft tissue information to help your surgeons in particular deliver injections or deliver surgical interventions to remove bits and pieces. they can both be used to provide you with additional information and understanding, if only it is translated and instilled upon you or given to you in a digestible and proper format over a reasonable period of time, not 5 minutes in the treatment room. It can be used as an education tool, both of them. However, the X-ray imaging, by nature of the fact that it's more likely to be load-bearing than the MRI, because it's just not logistically possible in most cases, as we discussed, or financially, the X-ray imaging can give us that load-bearing, that alignment side of things, that education that can really, really inform the patient going forwards, can help you better understand your own body and how it works in the world and how that injury fits into your back, and the factors that have so often led to the back pain or injury, and certainly have been perpetuating that problem. Ultimately, it's a tool, just like anything, and it can help you move forward in a more effective way. So if I had to choose one, we have had to choose one over the years, and that's why we would choose the X-ray imaging. That gives us such better insight. And the amount of times it just helps a patient feel like they have control over themselves again and over the pathway forwards. It doesn't take the pain away when you find out those things and when you go through those discussions, but it gives you a feeling of, hey, I can do something about this because I now understand the problem a little bit better. But again, you need the image and you need the time to be able to relay that information to the person. So hopefully this has been an interesting episode for you guys. It's given you something to think about when you're thinking about these two images. I know that you're going to be told that X-rays are a waste of time, and you're going to be told that you need an MRI because of the viewpoint and the trajectory that your treatment pathway is on, especially if you're getting things done within the NHS. That is the way things are done, and that is why we're doing them. We're not doing these images to educate you fundamentally in the NHS, and that is a little bit of a dig because it could be so much better, but you're not being given that information. Normally it's just, there's a report, off you go. They're not being used, or they're not used conceptually within our current system to inform the patient. They're just used to inform the practitioner or inform the surgeon or inform the doctor to do their things. And I think fundamentally we're missing a real trick, because imaging can be so impactful for the patient to help them understand, if only it is translated and used and that wisdom imparted through a qualified person on the patient, so they can be much more involved in the recovery process. So, sure, some patients want it to be passed away. They want someone else to deal with their problem, but those patients don't do well. You can try as much as you might, but you'll get short-term success because you're not taking accountability. It's your back, and anything that can be done to help you understand your own back better will be a boon to your recovery prospects. So thanks so much for watching this far. If you did find it helpful, give us a thumbs up. If you've got any questions, use that comment section. And if you do find the podcast helpful or insightful or just interesting for you, consider subscribing to the channel. We put them out every single Saturday/Sunday, and hopefully we'll see you on the next one. Thanks for watching.